and welcome to another video from the CTAD Clinic. My name is Dr. Mike Lloyd, I'm the Clinical Director. So today I'm going to be looking at what's called somatoform symptoms. So this is something that we see a lot in clinical settings. So most of the folks that come through the clinic have some form of somatoform symptom or another. And this is largely where the body is experiencing some physical aspect of the trauma. And what that means is that the psychological distress from the trauma is converting itself in a way into physical sensations. So people experience a wide range of physical things as a result of the stuff that they've gone on in their life. And this causes people problems because one of the myths or one of the things that people get faced with often in medical settings or in psychiatric settings is this phrase, it's all in your mind. So the implication of that is that the person is imagining or creating their own symptoms and the symptoms don't really exist. We know that's not the case. We know that actually the symptoms do exist. The physical sensations actually exist, but there's often no medical or organic cause for that. What we're seeing then is that the person is experiencing a load of symptoms for which the body is creating these as a result of trauma, but it's not an inherent disease or illness process within the body. So if a person hurts themselves, if they bang themselves into a wall, the body gets a bruise, right? So we understand that the physical symptom, the bruise, is manifested from a physical cause. You bang yourself into a door, you get a bruise. What we're seeing here is that symptoms that are being experienced are not coming from that physical cause. Now, they might be a long way back in the person's past, and that's where we get into the territory of things like body memories, and maybe we'll discuss that later on. But where the body is actually demonstrating a symptom, but it's not there in the body. So it's coming from the mind, if we see the mind as being where the past sits. So the traumatic experience sits within the mind. That is then creating physical sensations which are experienced as being completely real. So this isn't imagined. None of this is in the conscious choice. So a person isn't choosing to have pain. You can't make yourself be in pain. That's just simply not possible, but you can experience pain as a result of things that happened a long time ago. Now we know this can happen on an emotional sphere. So if you think about a very sad, like a bereavement or a loss or something like that from a person from your past, you can begin to experience sadness. You might even start crying. So that's fair enough, right? The body is creating a physical sensation. You experience sadness. You might start sniffling. You might start feeling sick. All different things that might take place because of a thought or a memory of something that's taken place in the past. If you think about something stressful from the past and really immerse yourself in that memory, your heart rate might go up, your pulse increases because you're experiencing a shift in physical sensations as a result of something you've been thinking about. So if pain, if trauma is resident and present in the mind from past experience, it would make sense that it can play itself out in the present day as a physical symptom. So it's not really all in the mind in that it's not being experienced as being false, but the mind is generating the physical sensations. There's no common or present reason why that should be taking place in the moment on a physical level, and yet there it is. And there's some really great writing about this. So people like Ella Ninehouse, Richard Lowenstein, Colin Ross, they have written lots and lots about this. So we know that there is a link between the somatoform sensations or disorders and the dissociative disorders. They overlap. And that's why we use the somatoform dissociation questionnaire, because that's a really good way of being able to get a picture as part of screening of what kind of things a person experiences. It's very unusual for a person to experience no physical symptoms whatsoever if they have a complex dissociative disorder. It will nearly always play itself out somewhere. That's our experience. As a sort of a guide though, it's always worth having this checked out because you don't know. Some of the symptoms you might experience, you say, well, that's traumatic, therefore I don't need to go to a doctor. Actually, we would always advise that these medical things get checked out just in case there is something going on, because things like pain or things like stiffness could be related to conditions that are medical and not just trauma. So there could be overlap. You might have both. You might have a traumatic pain response and actually there could be an underlying cause. So it's always worth getting this stuff checked out. What I'd like to do is just go through the main components of these somatoform disorders as we see them. So this is the common stuff that we see time and time again in clinical practice. So the most common symptom that we get is unexplained pain or sensations that are related to trauma. Sometimes there's an inability to feel pain, so we have that sort of analgesia aspect to it. Or there could be a physical numbness, which is more of that anesthetic type thing. So where a person cannot feel pain, or they don't feel pain in that moment, but they feel numb instead. Absolutely, though, pain can be experienced, and it can be specific located pain related to trauma. For example, a reminder of something that a person went through could be located in a specific part of their body, or it could be quite general because there's an overall sensation of pain. It's the distress of the body being communicated. Another common feature is paralysis, and this can be quite difficult because it can happen, say, on waking, or it can happen at different points in the day, and it can be quite a widespread paralysis, so the person can feel very paralyzed completely, like they cannot move at all, or it could be that parts of the body might be paralyzed, so it's full or partial, variants and in between. We also see loss of physical function without any medical cause, and this is quite an interesting one. And when we say loss of function, what we mean is things like it could be movement, it could be sight, it could be hearing, it could be taste, touch. The sensory experience that we take place in the world might be absent. So a person might have periods of blindness or periods of deafness. These are episodic, these occur, and they are not with organic cause. Always get it checked out again, but these are happening as a result of something traumatic in the past, not an organic problem in the present. Temperature and hunger are really wrapped up with this. So we speak to quite a few people that just don't seem to know when they're hungry, they don't seem to know when they're thirsty, and they really struggle to know whether to be hot or cold. So you might be constantly being told by people that, you should put a coat on because it's freezing cold, but it just might not be felt. The body will feel the cold. So it could be that your extremities, like your fingers and your lips, might be turning blue, but you just wouldn't get that cold feeling being experienced on the inside. Could be the same thing with heat. You're just not really very good at understanding heat. And obviously there are problems with this. Dehydration, sunburn, frostbite, all of those kind of things can take place if a person is not tuned into the physical nature of their experience and they are absent, dissociated from their physical experience somehow. People also experience somatic perception change. So the things that they see around them are not being seen or being felt as being correct. This is really part of that derealization disorder aspect. The previous bit would have been depersonalisation. This is more derealization stuff, where that actual, the sensory experience of the world is not being taken in or being distorted somehow. And lastly, we can have the seizures, the collapses, where people are falling, where people get really sort of spasm either in small parts of their body or as a complete feature of the body. These are non-epileptic, they used to be called pseudo-seizures. These are non-epileptic in form, and they would not show up in neurological scanning, and yet these things are taking place. Time and time again, people experience this kind of stuff. It can result in falls, it can result in damage and actual sort of physical harm if this isn't looked after properly. Again, these are not intentional, so these are things that are happening to the person, not because of the person. It's because of things that would have taken place a long, long time ago in that person's life that are being replayed in the physical, in the here and now. It's really important then to have within therapy to have a formulation of this, to try and understand the variation, the pattern, the onset, what it then brings about as an impact or a consequence in the here and now. So trying to get a really good picture of exactly what the symptom is, when it happens, as a result of what, and what is then the consequence. So in psychological terms, we have the classic ABC, the antecedent, the behavior, and the consequence. So we look, the behavior then being the physical thing that's happening to that person. Understanding the full picture of that gives us a real sense of what might be happening. And therapeutically, that gives us some clues and indications as to where to help that person being able to understand that movement of the trauma and the physical and the consequence, so that we can help them become empowered to start managing those symptoms, or at least be less distressed by them. The key then is that we have to take into account that these are happening. To dismiss them, to say it's all in the mind, is incorrect. It's not fair on that person to say you're making all this stuff up or you're imagining it because I can't see it on a scanner, because I can't see it on an ECG, it's not happening. That's not the case. It's really important to be able to know that these things are being felt by the person. That's their experience. That has to be understood, taken into account, taken seriously, and then formulated to work out how to make this improved for that person, because living with trauma from the past and then experiencing a load of physical sensations in the present, that's awful for people. So it's really, really important that we are able to work out what might be going on and then develop a plan for how to actually approach it, and ideally improve the symptoms as we're improving that person's response to their traumatic experience. So these things are all really taken into account. We can't separate the physical from the psychological. It's not enough just to say you were traumatized and therefore you experience psychological distress. We know that being traumatized equals psychological distress and a high proportion of physical symptomology that is being played out day after day in that person's life. And actually a lot of people say that stuff is worse than the psychological because they're just dismissed from it, because it makes their life so difficult. So it's really important that we get a handle on this, and that's what we try and do in clinic. We bring that physical stuff into the therapy setting, make sense out of it, ideally try and improve it. So I hope that's helped. It's a funny word, somatoform. Basically it just means the physical realm. That's what we're looking at. And we've got conversion symptoms are a part. So let's say, for example, a person experienced or witnessed traumatic events in childhood, and then later in adult life they have episodic blindness. They are triggered into becoming blind. They cannot see, but there is nothing wrong with their eyes. Very episodic, it doesn't last for very long, and it's a protective feature. Makes sense, doesn't it? If you think, I saw something awful, I don't want to remember it, I don't want to see it again, so you become blind if you're triggered. It's not true blindness, obviously, but the lack of sight is present, is experienced for that person. They have to be safe when that's happening. It can be very, very difficult, can be very, very distressing. So this somatic conversion, this realm of the physical, of the pain, of the stiffness, of the sensory experience, we bring this all into the clinical setting. We try and make sense out of it. We take it seriously. I hope this video has helped. It's useful to sort of bring in some of these things to try and help people understand why we use this somatoform dissociation questionnaire as part of our screening, because we want to know this stuff. Many centres, many clinicians use this as a really helpful tool. It's very, very quick to fill out. It's on our website to download and have a look through. It's a simple 20-point questionnaire, but it can give us so much information about what's going on. Well, as always, please leave any comments in the section below. Obviously like and subscribe if you enjoy the video and you'd like further content, and we'll keep producing these as we go along. So many thanks for listening, and before we do the next video, please do take great care.